So thank you for having me up here today. I'm one of the newest providers at Children's Hospital of Wisconsin. Prior to returning to Wisconsin, I'm a Madison native. I was down in Arizona, and I was a pediatric sports medicine provider down there with Phoenix Children's. And then upon coming back here, was able to get a position working with Dr. Kevin Walter, which many of you may have worked with in the past, or patients do. He's been in the area quite some time. And I've been fortunate to work with him and learn from him and our other providers within our comprehensive sports medicine and concussion clinic that we have based primarily out of our Greenfield location. That location, in addition to primary care sports medicine providers, we also work with neuropsychologists, and we also have a psychologist on staff who helps us with some of our patients who have prolonged recovery and need cognitive behavioral therapy. So, update on pediatric concussion, the newest Zurich recommendation, sounds like Berlin recommendations recently came out this year. We'll touch base on that a little bit. And also talk about some other studies that have kind of changed the way we think about concussion in treatment and treatment algorithms. This talk is very well timed, as it is, as we say, down at our institution, concussion season, and we're seeing a lot of these kids coming through our doors, and I'm sure you are as well. I'll try to get through this as quickly and efficiently as I can, so there's time at the end for questions. And if, again, volume or speed is not appropriate, just please let me know. I have no disclosures. So, four main objectives today: understand how to diagnose concussion in a pediatric patient, how that might differ from an older patient, whether a teenager or even an adult. Understand appropriate management of pediatric concussion, become familiar with typical recovery course and risk factors for prolonged recovery, and then become familiar with some of the initiatives in regards to prevention strategies that are ongoing and continue to develop. So quick slide on epidemiology. I'm sure many of you are familiar with the statistic, but anywhere from 1.6 to 3.8 million sport-related concussions occur in the U.S. annually. Concussion represents about 5 to 9% of all sport-related injury. About 30% of concussions that occur in 5 to 19-year-olds, so our pediatric population, are happening in some type of sports activity. The emergency rooms, in addition to some specialty clinics, are seeing a huge increase in sport-related concussion visits over the past 10 years. We suspect a lot of this is due to the increased awareness of concussion. Parents are understanding it. They are seeing things in the news, want their kid to be seen right away to make sure there's nothing that they need to be concerned about. Kids are being more forthcoming when it comes to symptoms that they're having, and so the emergency departments are seeing a huge increase in visits for this population. We know that girls sustain more concussions than boys in gender-comparable sports, so soccer, basketball. Currently, there is no high-level evidence to suggest why this may be. There's been some theories, including hormonal differences, other biophysical factors that may differ between boys and girls that may be responsible for this change. There have been some studies looking at neck strength in relation to head mass, and that's not really, the data on that is equivocal. So we don't really know why this is completely. We do know that there's more concussions sustained in competition versus practices, which makes some sense. There's more at stake with competition. Kids tend to, give up their body more, tend to not be, as conscious or as concerned in some cases about getting hurt, and more worried about winning. In addition, when you're in practice, you're probably less likely to, lay out your best friend as he goes, over the middle to catch the pass than you are the opponent of your biggest rival team. So, unfortunately, with as much as we're learning about concussion in the past decade, we still have limited data when it comes to youth athletes. And a big source of this is just due to the fact that it's difficult to track and difficult to record that data on the youth sports fields on Saturday mornings, or even in a club setting. High school, we have a bit of an advantage given there are athletic trainers in many high schools, enough. About 50% of high schools nationwide have an athletic trainer, but really at the youth level, there's not a way to track this consistently. Some of the best data that we have in regards to concussion in sport at the youth level would be this high school Rio data. This was, they track this yearly. They track concussion incidents and recovery times and things like that through this data. The athletic trainers are in the high schools that are typically entering this data. This was published in the American Journal of Sports Medicine in 2012. This was approximately 2,000 concussions that were reported across 7.8 million athlete exposures, and an exposure is either a practice or a game, or a competition, I should say. Not surprisingly, highest numbers are occurring in football, girls soccer, boys wrestling, and girls basketball. But the rates are highest in the sports we'd expect, sports with highest levels of contact, football, boys ice hockey, and boys lacrosse. And then again, not surprising, player-to-player contact is the most common mechanism for concussion, followed by player-to-plane surface. This just puts some numbers to that. I won't go through everything, but the highlighted portion at the bottom, it just shows you that in gender comparable sports, girls sustain injury, concussive injury at a rate of about 70% higher than boys in gender matched sports. And again, the reason behind that is not clear at this point. Looking at mechanism of injury across various sports, overwhelmingly, player-to-player contact is the most common, but we can take a sport like swimming. We wouldn't expect to see that in that sport. So with swimmers, it's more likely player-to-plane surface. Bump their head on the wall, slip down the pool deck, something like that. But overwhelmingly, with any sport that is a risk for contact is the most common mechanism. A few years ago, JAMA Pediatric published a study exclusively on soccer athletes, and this was a fairly large study, so about 1,000 kids were enrolled, slightly more girls than boys, and they found, again, contact with another player was the most common mechanism of injury, followed by heading. But within taking into account the different ways kids were injured in the act of heading, overwhelmingly, contact with the other player was the most common cause of the injury, not the ball hitting their head. So about 80% of heading injuries in boys and 60% in girls were caused by actual contact with the other player and not contact with the ball. Conclusions from this study, raise some questions. Well, if there's this huge risk with heading in youth soccer, and USA Youth Soccer recently published some recommendations regarding limiting heading in soccer. They said, well, that's great, and yes, we think that could have an effect, but what about looking at other ways to limit contact, aside from heading? And this is still being discussed. It's kind of up for debate. How would that change, the fundamentals of the game? Similarly to how it tends to always be a hot button debate at all of our sports meetings and also at pediatrics meetings regarding tackling in football. If it should be allowed ever, when, how. It's really a hot button topic when it comes to kids in contact sports with the data that's emerging. So just a quick slide, features of concussion. The Zurich International Conference on Concussion in Sport defined it as a complex pathophysiological process affecting the brain induced by biomechanical forces. So I'm sure I'll go back and explain this to patients. They'll say, okay, yep, I understand. I typically tell patients it's an injury to the brain that we can't see. It's a functional injury. It's something that, with all of our conventional neuroimaging studies, so our CT scans or MRIs, is essentially invisible. The injury happens at the level of the cells, and we're not going to take a sample of your brain, which they're typically in agreement with. But it makes sense. Your brain is soft, your skull is hard. You have a force either directed to your head or your body. That soft brain moves inside that hard skull, bumps up against the skull. There can be some deformation and then rebounds, stretches into those nerves, and that really sets off this metabolic dysfunction, and that's really what we're seeing when we're seeing these the various symptoms of concussion. May or may not involve loss of consciousness. I think this is fairly well known at this point. I rarely have anyone coming in anymore saying, oh, well, we didn't think it was concussion because we didn't lose consciousness. So that's not typically something that we could explain to patients in clinic. Concussion symptoms, they're variable, variety of physical, emotional, cognitive symptoms. Patients can present with any one or combination of these. I explained to patients that concussions can look different, in different kids. One sibling can have concussive symptoms that are different than another, and even different concussions in the same patient can look very different depending on what's going on. And the difficulty with this is that these are not specific to concussion, and it can be obvious or not. I shouldn't say that, but it's easier to diagnose concussion when you see things like in these pictures. You see someone down grabbing their head, someone's unconscious, a child sitting at the bench, really emotional, crying for no reasons, really doesn't seem to be like himself. In the top left there, that's Michael Caputo, player for the Badgers a couple years ago when they were playing Alabama, and he had an injury, got it from the turf, didn't stumble around, for all intents and purposes looked fine, but then lined up on the wrong side of the ball. So he's lined up on Alabama's side as they're about to snap the ball. And so, obviously this was identified very quickly. He was removed and went through concussion protocol. But we're seeing more and more, and parents are more aware, kids are more aware that you don't have to have this type of picture to have a concussion. They're aware that lots of smaller hits can cause concussive injury. A lot of them are aware that there can be delayed onset of symptoms. So a lot of times that we're seeing in clinic, and I don't know if your clinics as well, patients coming in and they have any one of or few of these symptoms, and it's almost like, well, could he have had a concussion? Because these are symptoms of concussion when I Googled it, and I'm concerned. So it can be really hard to tease this out. Timing is very important, trying to pin them down on exactly what they're feeling, what brought on these symptoms. I had a patient just yesterday who, came to clinic to me evaluated for concussion, and he is a football player, 13 years old. Remembers taking kind of a big hit on Tuesday, but had no symptoms, finished his practice, was fine Tuesday night, Wednesday. Thursday went to football practice, and later that evening kind of had a little bit of headache, didn't feel quite right, but didn't remember anything specific in his practice on Thursday. And then Friday had lingering headache, but also spiked a fever over 103 and had a sore throat. So now it's like, well, is this headache and not feeling well related to concussion, but you also have this fever and this sore throat. And then this concern because the fever went away, but he's still got headache. But it's definitely a muddy picture when it comes to some of these cases. And I'm looking at these things, is this definitively concussion? Well, the problem being those symptoms are not specific. It's a clinical diagnosis, and I don't have a definitive black and white test to tell you, yes, this is, no, this isn't. Your son's 13 years old. I can't tell you for sure today. This, if we're going with his history, would be his 4th concussion at age 13. We are going to play this safe and kind of watch how these symptoms evolve over the next week, because he was only a few days out. So, it's definitely a challenge. So this is probably familiar to many of you. This is the Sport Concussion Assessment Tool. This is published in the British Journal of Sports Medicine. This is the 5th version of it. This was born out of the International Conference on Sport Concussion, and again, now it's 5th edition. There's no big changes with this version. It has, the first page is really on-field assessment. This would be done by likely the athletic trainer, if there is one, on the sideline of a high school football game or a youth event where there's athletic training coverage. Looking for observable signs of concussion. It has the Maddox questions, kind of asking them about to see if they're oriented, who will be playing, who scored last, and trying to tease out whether in an efficient way whether or not this patient might have sustained a concussion. Has the Glasgow-Coma scale on there, and then the cervical spine assessment, which is really important because if you think about how these concussions happen, I mean, it's similar, the similar mechanism to how significant cervical injuries happen, and if we're more focused on the concussion and the head injury, we can sometimes forget about the spine assessment. Sometimes people come into clinic and they'll have this for me, they'll have a trainer filled out. Honestly, it's not all that, it can be helpful in some cases, but if it's otherwise clear cut, we don't test them again or ask them, we don't really follow anything based on that initial assessment. We're more likely to follow something like this where we have them give us score their symptoms, and I apologize, the symptom score. Didn't get on. But we use a symptom checklist when they come in, and that is what we use in clinic to track how they're doing long term. So they give us their symptoms at the first visit. We explain this is how you feel right now today in clinic, and then send them through a battery of cognitive tests. They just backwards, immediate memory, delayed recall. They do a neurologic screen, and then the delayed recall and the balance examination. And this tool is really meant to be used for people who are trained to use it. That's where it's most effective. In our clinic, we have a set of trainers that are physician extenders, so they're typically the ones who are administering this even before we go in the room. We have this data. If there's any question or they have a specific concern about any one of these elements, then we'll repeat it. And then depending on how they do, we don't always have them do all these steps in follow-up. If they did fairly well in their initial one or their second visit, they're doing pretty well, and we're able to pass all these. And we don't always have them do every visit, but definitely the symptom checklist we have them do. There's also the child version. So this is meant to be used in children who are 5 to 12 years old. We just ask questions in a different way. Some of the questions that are asked the other scat form don't make sense to younger. Even these can be difficult. There's also a spot where parents can answer the questions. And so in these I find somewhat helpful in clinic, but I really like to ask the patient and the family, or more the parent, how does your child seem to you? How are they doing in their day-to-day life? Are they playing like they normally do? Are they eating normally, sleeping normally? Are teachers calling saying, hey, Johnny didn't seem right today? That's really kind of more interesting when it comes to these really young kids, because that just adds an extra element to the assessment when they're really young. And they're kids. Some of these questions, my child has difficulty, sitting still and things like that, or not being fidgety. I mean, that's a child, so they're going to mark the highest number on any given day in the absence of concussion. So can be useful, but again, it's a tool, it's a piece of the puzzle, and the writers and the developers of this assessment tool recognize that as well. So concussion is not, it's not one test, it's not one objective measure. It's kind of a constellation of assessment tools in clinical judgment. This is the Pocket concussion recognition tool. This is very useful for people who don't necessarily have a lot of training when it comes to concussion assessment. So, you give them all this full scat sheets, like I don't even know where to begin with this. But then the biggest thing is recognizing concussion early and getting that child off the field and decreasing their risk for having another hit if they are concussed. And this is, fairly simple. Talks about how you recognize a concussion. What symptoms you might see. It has the memory questions there. So what venue are we at today? Which half are we in? Who scored last? Did your team win the game? And this is found to be more useful in terms of assessing whether someone has cognitive dysfunction than, what's your name and, how old are you? These questions are a little bit higher level that they would have to work a little harder, and even very symptomatic children would likely be able to tell you their name and how old they are. This also has some flags on there, what needs to be, sent 911, called immediately. And this can really be helpful, especially in those youth level activities where there might not be trained medical professionals on the sideline. And if there's a team mom or dad who wants to keep this handy and can have it there and make a quick assessment, or if there's any concern, hey, this kid really should go back. On-field assessment, so excluding C-spine injury is important. Obviously, first and foremost, ABCs if you have a player that's unconscious, knocked out, and then making sure that we're not ignoring a potential C-spine injury, removing the athlete from the field of play, getting them evaluated by a trained healthcare professional, and then close monitoring in the hours following the injury. So not every kid needs to go to the emergency room for a concussion. I always tell families, some families are more comfortable, they've had their kids had concussion before, depending on what they do for a living or their experience. they might be more comfortable looking for signs than other folks. I always say, if you're concerned, take them in for evaluation. But for those who say, yeah, we kind of know what's going on. My son, they're talking to me, or maybe they've had a trainer evaluate them on the sidelines, so someone has seen the child, in the minutes or hours after injury. Close monitoring in the hours following injury is important because things can change. They can be up and functioning, 15 minutes afterward, and then in the hours that occur after that, there can be declining mental status, worsening headache, any vomiting, numbness to the knee, extremities that turns you to the ER immediately or call 911. So treatment. So, excuse me a second. Very well known that a mainstay of treatment with concussion is physical and cognitive rest. How much physical and cognitive rest is evolving, and we'll get into that more in some future slides. But ultimately, right away, patients concussed, you take them off the field of play, and strict physical rest, especially in the initial few days, is still recommended. We keep them out of their practices, their training, their gym classes, and definitely have anything that would put them at risk of being hit in the head. We have this picture here of a cocoon. Back many years ago, there was thought that so-called cocoon therapy, mostly out of studies that were done on the East Coast, are thought to be the best way to rest a patient with concussion. So you put them in a dark room, concussed on Friday, put them in a dark room throughout the weekend, you let them out on Monday and they're fine. And that probably works well if there's someone whose symptoms get better in those few days, and so it seems like it worked. But as the years have gone on, we realize that, on average, concussions don't get better in 3 days. Concussions, all comers, 7 to 10 days is the average, and when you're talking about younger athletes, they are more likely to have even a longer course, a longer symptom recovery. And we can't keep them in a dark room for weeks on end. And that's, inhumane, and also does not make them any better, and would definitely make them worse. So over the past decade, there really has been evolving, the treatment of concussion has evolved, and we're saying, well, how much rest is it? Cocoon therapy was thought to be it back in the day, and now we're saying, well, that might not be the case. Well, when can we get this started, and is it dangerous? And we'll talk a little bit more about that in a few minutes. Cognitive rest, important. We don't want to be, have the kid concussed on a Thursday night and send them back Friday and expect them to take 5 midterms. It's not dangerous. I tell kids all the time, it's not dangerous if you go to school and do too much math or too much reading. Your symptoms are probably going to get worse. You're not going to feel well, but we're not causing worse injury. What causes worse injury is having hit to the head before you're recovered, but cognitively we're not causing damage. We don't want you to exacerbate your symptoms and feel poorly and do bad on your tests, but it's not dangerous. Initially, the first few days, kids may need to stay home from school. Some of these kids can be pretty symptomatic, but after those first 2 to 3 days, we really advocate for them getting back into the classroom, even for a few hours those first few days. In our clinic, we really, by a week, would hope that they can be back in the classroom, in school full time with accommodations. That doesn't mean they're going to every single class, sitting in every single hour, and doing all of the workload that all of their classmates are doing, but it's just getting them up, getting their time schedule, their sleep schedule back where it used to be. They're sitting in class, they're learning, they're at least hearing some of what the teacher's saying, but then we provide them letters that request some accommodations, like decreased workload, so they don't feel overwhelmed, potentially pre-printed notes so that they have the notes there, they don't have to worry about feverishly trying to write it or remember what the teacher just said, because their brain is injured, they're not processing things the way they normally were, they're having issues with concentration, so we provide them a crutch, if you will, to get them through that period of time so that they can get back into learning, they're not falling behind, they don't feel like they're that they're just kind of drowning with this injury. I say, well, we don't expect you to be where you were prior to this. We don't expect you to get the same grades you did before and be as quick to pick things up. It's similarly to how we wouldn't expect you to, run the mile in gym class just as fast as you would on a healthy leg as a broken leg. So we provide a long list of accommodations for kids, and we tailor it to their individual needs. We typically recommend that they don't test until they're back in school full time, and then when they do return, that they only be given one test per day. It's not really fair, you missed 5 days of school and you had a test every day. You just show up the next week and they say, oh, good, you're back. Sit down and here you go. And again, they haven't had time to study. I mean, really, we count on the teachers and or guidance counselors to work with us and the students to provide a reasonable return to learn plan. And there's a great guideline published in the journal Pediatric. It's in my reference slide on returning to learn, and gives very specific recommendations and can help with what accommodations kids might need depending on their symptoms. It's really easy, avoiding overstimulating environments. It's really easy to write a note saying, hey, eat lunch in a different room with a friend, avoid the noisy hallways, so passing time earlier or later than the rest of the other kids, avoiding music and tech ed classes, at least initially. Once they start to feel better, we let them ease back into those. And then limiting screen time. We don't say limiting screen time when kids live for screens these days, and to tell them they can't do anything on their phone, can't text their friends, can't be at all plugged in, does wonders for their mood, and it doesn't tend to help with their recovery. So, initially, yes, we are more aggressive with shutting down screen time, especially if that's one of their triggers. But, after the first few days, if they're feeling better and they're not, on 24/7 and not using them to the point where it's increasing their symptoms to where they're telling me, well, I can't do my homework now, or I can't be back in school because my headache's so bad, then we let them have their screens back. We ask as much as possible that the teachers give them paper, pre-printed notes, or actual textbooks. That can be a problem in the age of Chromebooks and tablets, and we sometimes struggle with that. If they have to use a tablet, we ask that they be given breaks, dim the screen. Potentially they need to be reseated in class. The smartboards tend to be a problem if they're up close, or if they're having visual issues, they may need to be closer than they were before, so that they can see better and may not have to turn their head certain ways for our kids who have vestibular dysfunction. So in terms of physical rest, there's emerging data that we may not have to restrict them as strictly as we have in the past. This was a great study actually out of the emergency department at Children's Hospital, published in 2015 in the Journal of Pediatrics, and Danny Thomas and his group did a prospective randomized controlled trial, looked at 88 patients that were seen with a concussion in the emergency department, and they assigned them to 2 different treatment arms. So one group was told strict rest for 5 days. You don't go to school, you don't use a screen of any type, you don't do any type of physical activity. You basically wake up and sit around and eat a few meals and go back to sleep. And then that was in contrast to the group that was given instructions for, quote, usual care, which was 24 to 48 hours of taking it easy, potentially not going to, if they were feeling bad, not going to school. But then after that time period, on their own, kind of gradually progressing their cognitive and physical activities as they felt better, and to a degree that did not significantly increase their symptoms, aside from contact. They could kind of just, if they wanted to go for a walk, they could. If they wanted to shoot baskets in the driveway, that was fine. Going back to school, using screens at their discretion. And then they followed these kids. So in the emergency department, they were given an impact test, they were given obviously a clinical exam, and their balance was tested. And then they're sent away, told to keep a log of their symptoms, brought back at the 3-day and the 10-day mark, and retested with impact. Balance testing was retested, and they were re-examined. And what they found was that there was no clinically significant difference in neurocognitive or balance outcomes between the 2 groups. But they did find that the group that was prescribed strict rest reported significantly more daily post-concussive symptoms, and their symptoms were typically slower to resolve than the kids who were kind of told, okay, once you're feeling better, you can kind of start to do low-level physical activity, text your friends, and obviously nothing dangerous. And so this, this kind of was one of the studies that changed the way we think about how much rest we should be prescribing in these patients. And in our clinic, we started to, definitely get away from saying strict rest. I think I rarely ever say that anymore, unless it's a kid who's feeling horrible. We're in a dark room, they're curled up on the table and can barely sit up without symptoms, that kid probably shouldn't do too much. But so, once you start to feel better, it's okay to do a light walk. It's okay to I guess do light things outside with your family, not just not doing gym class or any type of practice activity, but it might actually help you be better faster. Other treatments we talk about, obviously just optimizing sleep for other just overall health reasons, and we know that the brain needs rest to recuperate, so I recommend 8 to 10 hours minimum per night. Not waking the athlete at night, don't secure that too much these days. Sometimes we'll tell families to do that if it's like a Friday night and it's 9 o'clock and that's when their kid was concussed and we're trying to monitor them for those few hours. We probably shouldn't let them go to sleep right when they get home. Not necessarily let them go to sleep and wake them up, but just keep them up for a few hours. When kids do have concussion, we tell the parents, the first few nights just let them sleep as long as they want. If they are really tired, they don't have to necessarily go to school for the next couple of days. But then we want to start to get them back on their normal sleep schedule. It's okay to take naps, but 30 to 40 minutes. We try to keep them fairly short because, again, what happens is these kids who are home or aren't regulated at all in regards to sleep, they can't do anything else. They're not at school. They aren't going to do they're not doing schoolwork at home. They're not with their friends, so they sleep 5-6 hours all day. And then they come in and say, well, I can't fall asleep at night because, you got all your sleep during the day, and then that makes it more difficult for us to get them back into class. Talk about hydration and regular meals. Those things can impact symptoms as well. When it comes to medications, there's no FDA-approved medication for treatment of concussion, and there aren't any great studies that show any significant efficacy with any of them. Acetaminophen, ibuprofen, naproxen, frequently recommended. That's one of my first time in clinic, over-the-counters. We do have to be careful that we're not overusing medication. Sometimes these kids will say, I have a concussion headache, which is going to be there. We know it's going to take time to resolve. It's your brain is injured. You're going to have this headache. It's not going to be like maybe your typical headaches where, I have a trigger, I have an exacerbation, I take my Advil, I get better. We have to expect some level of symptoms, potentially for several days, and throwing, every medication you have in your medicine cabinet at this every hour isn't going to help. And they'll come in often and say, if I take Tylenol, ibuprofen, intermittent, or alternating, and then I throw in Excedrin, and then maybe I take an aspirin, and they didn't tell me to take in family members' prescription medications, which is another issue, and nothing seems to help. And unfortunately, that's kind of concussion headache. These really don't consistently respond to medications well, and evidence tells us that as well. So I say, look, we have to kind of get to a point where we expect some level of symptoms, some level of headache. Really reserve using medications for when you feel a spike in headache that doesn't get better with removing whatever trigger you happen to be, if you're reading or you're looking at a screen, a short nap, drinking water. It's definitely okay to use these medications. We just have to be judicious with them. In my clinic, kids who come in who really are improving at the 3-4 week mark, having daily headaches that aren't responding to these over-the-counter medications. I'll prescribe typically amitriptyline as one of my first lines. Amitriptyline does have a side effect of drowsiness, which can be helpful in kids who are having sleep issues, sleep disturbance related to their concussion. I used to use nortriptyline. Some providers use Tobamax. I've done it in the past, but it's not something I typically use at this point. Typically, I prescribed it to a few patients I have. It was patients who had underlying history of migraine. Triptans can be helpful for abortive therapy in kids whose post-concussive headaches seem more migrainous. There was a study that was published looking at amantadine treatment for children who had persistent cognitive dysfunction. It did show an effect. However, the group that it showed the effect in was a group that had more significant issues preliminarily. So, it's not something I prescribe in my clinic really at all since I've been here. I did it when I was in Phoenix Children's. Some of my colleagues I never saw a significant effect in the few patients I prescribed it in. Some people will prescribe stimulants if they're having issues with concentration or heightened ADHD symptoms. I typically don't do that if they're already on medication and it's a kid who has had some prolonged concussive symptoms with an increase in their attention deficit problems. Then I will typically have whoever is their managing provider consider increasing their medication for a short period of time while they continue to recover. Talk about melatonin a lot in my clinic. over-the-counter supplement to help with any sleep issues they may be having. I don't typically prescribe trazodone, but it is something that some providers, some concussion providers will prescribe to help with sleep. And then antiemetics, I do prescribe Zofran, short courses for kids who are having a big problem with nausea, especially in the beginning. Other therapies that we prescribe frequently for kids, especially by the time they're getting into our clinic, they've tried things, they're usually at least 2 weeks in before they're seeing us. And so if they're still having symptoms, we start, in addition to potentially changing medications, we start looking at other modalities that might help them improve quicker. So a lot of kids, especially if they have a significant injury where they have like a whiplash type mechanism, we get them into therapy to help with cervical strain. A lot of the kids that come in complaining of persistent dizziness, issues with reading, lightheadedness, will have some type of vestibular dysfunction. We check them in clinic, look for any issues with smooth pursuits or fixed gaze testing, convergence testing. Our program, several of our we have physical therapists at each of our locations where we treat concussion, Delafield, Mequon, Greenfield, who have experience in vestibular therapy as well as cervical spine therapy, and so they'll usually do that in conjunction. They also are helpful in, we say, active rehabilitation programs for these kids, so when they're further out, they might have some C-spine and vestibular symptoms, but they also, especially if they're not an athlete, may not be that motivated to be active, and we know that there are benefits to physical activity, so we kind of just get them moving again. We say under supervision, they get them on the elliptical, they have them do some light physical activity under their supervision within the PT gym, and that can have benefit as well. Cognitive behavioral therapy is incredibly helpful to many of our patients who have prolonged symptoms, especially those who have comorbidities of depression and anxiety. I mean, having a concussion is anxiety provoking, especially for these kids who are, I'm an athlete, I'm supposed to be out there in the field, you've taken me out of my element, I don't even know what to do anymore, I can't go see my friends, I'm going to lose my starting position, and oh, by the way, I'm a 4.0 student, I, cannot have anything but an A+ on any of my grade reports. And so it's just this storm of anxiety and fear, and I mean, they just can't do it. And we have kids who won't go back to school. They might be feeling 80, 90% better, but they can't bear to go back to school and not be 100% because how am I going to go to my 5, 6 AP courses and perform at the level I need to perform, so they choose not to do it at all, which, well, now I'm falling behind. And, it's this huge, there's a lot of things that can go on, especially with those high-achieving kids. And so cognitive behavioral therapy can be, extremely useful to help them manage those symptoms of anxiety. Our cognitive behavioral therapist that we work with within our program is very helpful in giving them manageable school programs, manageable goals in terms of getting back into the classroom and kind of framing it for them in a way that makes sense and that they can cope with in terms of not being 100% at this point. Because often we'll be in contact with the schools, guidance counselors, and works really, really hard to help these kids get back to where they need to be. He helps them understand the mind-body connection when it comes to concussion, how your psychological symptoms can be significantly impacting your physiological symptoms, and at some point in concussion there's overlap, right? So they have this concussive injury, they have cognitive dysfunction, it sets up this extreme metabolic cascade within the brain that results in a variety of symptoms, but eventually the brain heals and gets better, but then we have this downstream effect where they're so anxious, they're so depressed because of everything that happened due to this injury, and so he helps us kind of navigate that course when it comes to the kids who are really far off from their injury and are having these downstream effects. We'll talk a little bit about progressive exercise tolerance protocols in kids who get better, but then have difficulties getting back into physical activity once we kind of give them the green light to start increasing their level of exertion. This is just a quick slide. I won't believe it. We're kind of short on time here, but it was a study published in the Journal of Neurology about analgesic overuse headaches and how this can actually make symptoms worse. So as a retrospective chart review, they identified 77 patients with chronic post-traumatic headache so they identified as 3 to 12 months out from injury, and they found that significant percent of them, about 70%, met criteria for probable medication overuse headaches, the criteria that they used at the bottom there. And they noted that once they gave them a plan to come off those medications and use other methods to help treat their headaches, deal with their headaches when they come on, they found a significant improvement in headaches to either complete resolution or improvement to pre-concussion pattern in about 70% of kids. So small study, retrospective trial review, but you know, there is some, I think, merit to this. I mean, I definitely see it in our clinic where these kids are just taking so many medications, and especially when they're telling me it's not making them better, I say, well, why don't we just stop them and let's, you know, try a different path. So in terms of recovery, as I mentioned before, most concussions, all comers, all ages, 7 to 10 days. But when you really split the groups of people out into age groups, the younger kids take longer. So when we're talking about children and adolescents, you know, it is not uncommon for them to take up to 4 weeks to get better. Really, we're not talking about or worried about really prolonged symptomatology until we're past that point in these younger kids. Again, most of them, 90% of kids are better by the 4 week mark. But we do know there's a small subset that do suffer from prolonged symptoms. Some studies suggest that there's a gradient level when it comes to age and or potentially level of play in concussion recovery. So for instance, you know, the players who are professional or NFL will take a shorter period of time to recover than your collegiate athletes and your high school athletes. And several studies have demonstrated that, but that may not necessarily be the case all the time. So a recent study, a multi-center prospective study published in 2016 showed that kids presenting to emergency department, multi-center, multi-sites, about 3,000 concussions, showed that actually it was the 13 to 17-year-olds, your high school age kids, who were having more difficulty with persistent symptoms greater than 4 weeks. And kind of for some of the reasons I mentioned before, just that increased stress and everything they have on, some of these high schoolers have on their plate, that makes sense. However, there's also, this also calls into question, or are they just more aware because they're able to describe what they're feeling and kind of understand what they're feeling as opposed to the younger kids. But you know, everything they do, I see more of a picture that they're showing here. I mean, the high schoolers tend to be in our clinics. The kids that we struggle the most with when it comes to getting back into their school and physical activities without having other stuff going on. There, in the past decades, kind of an explosion of studies looking at what could potentially be predictors of prolonged symptoms, and there has been, you know, initially, in the early studies, it showed that loss of consciousness and amnesia were strong predictors of prolonged recovery, and then as time has gone on, other studies have not agreed with this. So current data does not find a strong relationship between loss of consciousness and amnesia as predictors of recovery. More consistent factors include female sex, so that one has been fairly consistent across most studies, even as more information has come out in regards to having prolonged recovery and more symptoms. Patient history of concussion, both number and severity, has been shown to be a predictor of potentially having a prolonged recovery. And these patients who have had concussion in the past also tend to report more pre-injury symptoms as they enter their next season. Potentially they're just more aware of their feeling. You know, if they've never had a concussion, never been asked all those questions, how you're feeling, they may have never been aware before. And there's probably some component of fear and anxiety there as well. Mental health history, both personal and the family, history of migraines have been shown in studies to be predictors of recovery, prolonged recovery, if you will. And there had been data early on that was showing learning disorders and ADHD were predictors of prolonged recovery, but more studies have kind of washed that out a little bit, so it's inconsistent in regards to those conditions. However, those patients, there may have to be a more creative, and it maybe takes some more effort in terms of their return to learn plan. Some of them are already on IEPs at school because of their conditions, and so they add a level of complexity that may not be present with other patients. We know that sustaining subsequent head trauma while you're still symptomatic is a problem, both in terms of risk for second impact syndrome, but as well as prolonged recovery. A prospective study, again, is fairly small number, 69 athletes, placed into two groups. This is a study in Journal of Pediatrics recently. 34 were in the played group, so meaning they admitted to playing when they saw symptoms, versus 35 were in the pull removed group. And the kids who were in the pull played group took 2 times longer to recover on average and were about 9 times more likely to have prolonged symptoms. So this is one of the studies that I quote in my clinic when I'm talking to kids and saying even small, low levels of symptoms, because most of these kids didn't have, you know, they barely hurt, but, you know, my headache, it's not a big deal, you know, I don't have to take medicine, it's fine. I say, you know, because we don't have an objective measure of concussion, it's a clinical diagnosis, we have to pay attention to that. And that headache was not there prior to sustaining your concussion, so, you know, that tells me your brain just might not be ready to sustain another impact. And it can have significant consequences. So, you know, we're talking about training maybe a few extra days or weeks on the front end versus, you know, potentially months on the back end. And we do see these kids in clinic who come, who are with us for months and months and months on end because of prolonged symptoms. And when it comes to determining return to play and getting back into activities, or even talking about retirement from activity, the biggest thing we are concerned about in our clinic is the pattern of concussion. So I saw patients who come in and say, "Oh, this is my third one. I know I'm done. You know, WIA says my third one. I'm done." That is not a WIA policy. You know, I scoured the website to look, and I also, Kevin Walter, he writes the policy. So I talked to him, he's like, you know, I hear that too. And that is not, some schools will have policies 3 and you're done, based on what, I'm not sure, but it's not a WIA policy. There's no number that determines your retirement. We watch patterns. We watch to see, you know, are you a kid who's having concussions with lighter and lighter hits, suggesting potentially a decreased concussion threshold? Are you someone who, you know, with each progressive concussion, you have longer and longer time to symptom recovery? Are you someone who, you know, you have an injury, you get back, you send you back to play, and you know, maybe between your first and second injury it was 2 years, and then between your second and third it was a few months, and now you had another one a couple months later. Why is it that you're having injuries closer together? And those are kids that we tend to be more conservative with when we talk about return to activity. We hold them up longer, even when they become asymptomatic, because there's emerging data that says clinical recovery does not necessarily correlate with neurobiologic recovery. And so there's some work going on that looks at other biomarkers of injury that aren't necessarily back down to baseline after the patient clinically has recovered, and as of yet that's not ready to go live for prime time. We're not testing patients in our clinic. You know, we still, for everything we can test, you know, clinical assessment, all the tools we talked about, neuropsych testing, which we'll get into a little bit later, not too much later. You know, that's still the only methods we have to determine return to activity. And we know that kids who've had a concussion have a significantly higher rate for having a future one. So neurocognitive testing, not required. In general, some schools may require it, some teams may require it, but it can be helpful in assessing recovery and making return to play decisions. I don't use this in clinic to determine if they've had a concussion. We take their symptom score, we take based on our clinical assessment, and then once they tell me that they feel 100%, everything I can test clinically looks back to baseline, that's when I utilize the computerized neurocognitive testing if they've had a baseline that's valid, and use that to help with return to play decision. I explain, you know, everything we can test clinically, everything you feel from what you feel is back to normal. However, is there some underlying cognitive dysfunction you can't feel, and that's what this test, that's how I use this. I don't test them while they're symptomatic, because I tell them, well, if you can ace this test, you can do awesome on it, but you're telling me that you have headaches and sleep problems and you can't concentrate in school and you're only 50% back to normal, so this isn't going to help me at all, even if you do great. So not using it in isolation. And then it is important to have a valid baseline. We have kids who come and say, oh, look, here's my baseline test. I had it done, and their numbers are abysmal, and the test is, you know, the cognitive efficiency index, parasitic impact is what we look at to determine did they try, you know, did they even try? And a lot of times the answer is no, because they bring them into a room like this after practice and they set them up on computers and they have them do it, and their friends are next to them, poking them and talking to them, and they're texting, and you know, So if they don't have a valid baseline, then I won't use that as a comparison for return to play. So we talk about return to play. It's a graded progression. I'm sure many of you are familiar with this. So this shows 6 steps here, 6 stages. Stage 1 being, symptom-limited return to normal life stuff. When you're talking about the graded return to activity, it's a 5-day progression back to full activity or contact activity. If you're not a contact athlete, obviously you're not, steps 5 and 6 don't pertain to you. But for contact athletes, they do. We typically start this when they're the gradual progression when they're asymptomatic for 24 to 48 hours, in school with no accommodations, and testing looking back to normal if they have a valid baseline test or neurocognitive test. And then once they start in this progression, they need to do it in a stepwise fashion, 24 hours between each step, and they're not allowed to progress to the next step unless they successfully complete the previous one. If they have symptoms, they stop at the step they're at, wait till they're symptom-free for 24 hours, and then can resume at the previous symptom-free step. There are cases where, especially in younger kids or people who have had multiple concussions, where we tell them to go back to step 1 and we move them up more slowly. Again, this is a guideline. This isn't, there's certain situations where some kids, we say, okay, I want you to do two days at each step. And this isn't set in stone, and you definitely individualize it based on what patients are seeing. This is a study that was actually really groundbreaking. This is a study out of University of Buffalo. John Leddy and his group out there said, we see these patients who are taking a long time to get better, and the guidelines are we shouldn't let them do any activity until they feel 100%, and that's is this really benefiting them, and how long do we let this go on? Do we let this go on indefinitely? What if they never feel better? We know there are significant benefits to exercise, and so is there a way we can get them back exercising safely? And he demonstrated that yes, we can, and not only that, it actually people got better faster with this protocol that he initiated. So this is the first initial pilot study, and he has subsequently reproduced this data with larger cohorts. But what he did was he put them on a treadmill and using a bulky protocol where you set it at 3 miles per hour. You get a set of vitals, and you ask them about their symptoms prior to putting them on the treadmill. And then at each minute they're on the treadmill, you increase the incline by 1%. And they were checking their heart rate the whole time as they're doing this until they reach a level where they say, okay, I feel my symptoms have bumped up. So that's essentially their symptom threshold. What they then do is they have them exercise at 80% of that level, 80% of that heart rate level, for the next several, in between their tests. So for this study, it was every 3 weeks they tested them. So for 3 weeks, they're exercising at 80% of that level, and then they bring them back and test it again. And the hope is that, and what they demonstrated was they were able to increase that level with each successive test in most of the patients. And as I mentioned, they had decreased mean symptom score between periods of the baseline and the treatment, and they were all able to get back to their near their age predicted heart rate max. And at follow-up, 10 of 12 of these folks were asymptomatic at rest and all returned to their typical level of work and athletic activity. So great study, and I think this was also one of the springboards for, well, if we know it works in patients who have had symptoms for a long time, how long do we have to wait for them to have symptoms so we can start some type of activity? And I think this was somewhat of a springboard for looking at what we do with more acute concussions as well. So I'm going to breeze through this quick, so if there are questions. So prevention, there's been a lot of initiatives in regards to concussion and awareness. People have been looking at equipment. Is there a special helmet, a special headband, mouth guard, what have you, that can help prevent concussion? There have been studies that looked at technique and just exposure to contact in regards to preventing concussion and decreasing risk. Neck strength, fair play, rule changes, and there has also been some legislation that has been enacted to help decrease the risk of concussion and raise awareness. So when it comes to equipment, you get asked all the time, what helmet should I buy for my kid? What's gonna, we'll spend any amount of money. What's gonna prevent him from being concussed? And the answer is none. So helmets do not prevent concussion. They do a great job at decreasing the risk of traumatic brain injury, head bleeds, lacerations, things like that. but they do not significantly decrease the risk of concussion. These show the mouse. Yes, so this is the Guardian cap. This is a helmet add-on that came out several years back that, some people thought was the greatest thing since sliced bread. This is going to help decrease the risk of concussion. And these have actually been found to be more problematic for several reasons. Number one, it voids the warranty on the helmet. Number two, it increases your risk for C-spine injury, because if you think about helmets, they're slippery and they glance off each other, and these things are sticky. So there have been cases where kids go head-to-head and instead of glancing off, they stick. And there have been some catastrophic C-spine injuries in relation to having these on their head. And then when we talk about concussion, we talk about not only impact forces, but rotational forces. If you think about that, you're essentially adding mass to this head. So you could therefore be subsequently increasing the rotational force that this player would have if you were to get hit. So we do not advocate for these Guardian caps at all. The mouth guards also, they're great for accidental health patients. Great for your braces. Keep your braces out of your teeth and help prevent orofacial trauma, but do not have never proven to decrease the risk of concussion, incidence of concussion. And then headgear. The data on this is more equivocal. It's not strong enough that we recommend everyone have to wear one. Some parents want their kid to wear one. Kids love it when I say, well, there's no evidence that it significantly decreases. Some studies say yes, some studies say no, so sometimes that gets them out, but some parents say, I don't care if there's any chance you're wearing it. And so we see these, and it's not dangerous to wear one per se. There's some concern that it might increase, result in increased aggressive play, because they have these on, they think, oh, I'm going to go for that header now because I have this protection on my head. But there's been no science behind that, or strong evidence behind that. And there's one study of collegiate soccer players that showed it actually, similar to what I was mentioning with the Guardian cap, increases acceleration forces because you're increasing the mass of the head. Always want to make sure that players are playing with appropriate technique, that they have good control of their body to potentially help them react to hits, react to the forces that are coming at them. So, which may, there's no definitive data on this, but we suspect that this does, if you can prepare for a hit, you may decrease the chance that you're going to have your head snap back and have sustain a concussion. Neck strength. Studies show that yes, if we put you through a program, you can strengthen your neck. You might have an increase in neck girth, and this is all fine and great, except if you aren't able to prepare for the hit that's coming at you, it doesn't really matter how strong your neck is. There's no strong evidence that increasing neck strength at this point can decrease the risk of concussion. There's been several rule changes over the years in regards to with an effort to decrease concussion. Back in 1976, spear tackling was eliminated, and this resulted in a decrease in catastrophic C-spine injuries. There's been harsher penalties, fines, ejections, what have you, for, quote, dirty hits, so hits where the people aren't looking, don't have any chance to protect themselves, prepare for a hit, targeting in football, fighting fouls in basketball. There's been really promising data out of several studies that looked at eliminating body checking at lower puberty levels in hockey, and that actually has shown a decreased incidence of concussion with, essentially decreasing the exposure. Similarly, several football organizations at various levels, NFL down through collegiate, high school, youth levels, limiting contact practices. You're limiting exposure, limiting the amount of times that person's being hit in the head, and is that in turn going to decrease their risk of concussion? And some studies say yes. And then I mentioned earlier about the eliminating or limiting of heading in youth soccer. Recent guidelines came out in 2015 that there should be no heading for ages 10 and under, which this impacts the U11 level because some players on U11 teams are 10 years old, so there's no heading in games or practices at that level. And for the U12 and 13 levels, they recommend a limited amount of heading in practices and games. Wisconsin Act 172 is our state's legislation in regards to concussion. It's a guideline for coaches, players, and parents that they need to be educated prior to the season in regards to concussion and return to play. They get these information sheets distributed at the beginning of the year. If it's like through the school and they play 3 sports, 1 per year should be sufficient. But if it's club teams, every separate club should be requiring the kids and parents to be signing these. athletes, it's the legislation requires that they be removed from play if injury suspected and no return until evaluated by a healthcare provider. And this was inspired by the Lystat law. Zachary Lystat's a young man out of Washington State when he was, I believe, 12 or 13, had a sustained concussion in football, wasn't evaluated, continued to play, and actually developed second impact syndrome and had to have be life flighted and have craniotomies, and he's permanently disabled from that. He's in the bottom picture there. And his family and his treatment team has been instrumental in enacting legislation across all 50 states in regards to concussion and increased awareness and treatment recommendations. So, kind of, what would a concussion talk to you without talking about CTE? I'll be brief about this, but essentially, this is a disease, a progressive neurodegenerative disease that has been characterized by abnormal deposition of tau proteins in the brain. It can only be diagnosed, after someone passes away and you have a sample of their brain. The brain bank is out in Boston. You see a lot of this on the news and in the media in regards to NFL players, and they're coming up with a lot of data saying that there's significant evidence that shows hits to the head, concussions are causing this in these athletes. But the problem is there's no randomized, you can't really randomize these, but there's lack of a control group when it comes to this, and there's other confounding factors that may be impacting what we're seeing on these. With these samples, and the people's brains that they're looking at overwhelmingly are professional athletes, professional football players, boxers, and people who were showing symptoms when they were alive, and then their families submitted their brains to science. So I think we need more information about other players who played but did not have symptoms, and there's kind of a lack of a control group. And then the question is, well, how many hits? Is it how many hits to the head? Is it how many concussions? What are we looking at here? What are the real problems here? What are the real risk factors when it comes to my child? And there's as much debate as there is over the evidence at the professional level. There's even less evidence when it comes to, I played high school football, what is my risk of having CTE as an adult? And, it's scary. And I have kids, one kid just this week, he's got a concussion from a soccer ball to the head and was convinced that he was going to have CTE and was just, devastated, and just thought his life was never going to be the same. And so we had a long discussion that, no, you're not the one that the patient we typically worry about when it comes to having this. But currently the relationship to concussion and CTE is unclear, and that's what we explain to parents. And because we don't know, it's how comfortable are you with the unknown. Similarly to how comfortable are you having your kid out there at all. We know football is a higher risk sport when it comes to concussion. It's a higher risk sport when it comes to musculoskeletal injury, as compared to your swimmers. And so it's kind of a risk-benefit discussion and what they're willing to accept. So I'll spare the summary. You guys can read it on your own. And I have some references there as well. But I'm happy to answer any questions there may be for those of you who are. I apologize for going over my time, but it's a big topic.